Hi, Dr. Brian Koffman, a retired family doctor and a CLL patient myself, and the co-founder, chief medical officer, and executive vice president of the nonprofit CLL Society. And today I'm going to be talking about some of the most important papers from the American Society of Clinical Oncology's annual meeting in 2022. What follows is the patient-friendly summary of this research, and I'm going to start with the bottom line. CLL patients are higher risk for several types of cardiac events and have a higher rate of in-hospital mortality, regardless of why they were admitted to hospital. That's what this trial found. But this trial was seriously flawed in that it did not address what CLL treatments were being used, as we know that certain therapies, such as BTK inhibitors, especially ibrutinib, are associated with an increased risk of developing atrial fibrillation and hypertension. This research was presented by Dr. Ghulam Ghose from the University of Minnesota and others at the American Society of Clinical Oncology's annual meeting in Chicago in 2022. In the way of background, CLL affects mainly the elderly, and the elderly are already at a higher risk of cardiac disease. Add to that the fact that certain therapies, such as Bruton tyrosine kinase inhibitors, ibrutinib and acalabrutinib, are associated with more specific cardiac morbidities. Let me add another thing to the mix. Like all cancers, those with CLL often have higher markers of inflammation that have been associated with a higher risk of cardiac disease. Things like C-reactive protein, D-dimer, and IL-6 or interleukin-6. The researchers wanted to better understand the incidence, predictors, and outcome of cardiovascular events in patients who were in hospital with CLL, and overall the cardiovascular risk for those patients. So what was their methods and who participated in this trial? What they did is they looked at the national inpatient sample from 2019. It was a retrospective study using a large database of patients only in hospital. And what did they find? CLL patients showed a highly significant increased adjusted odds ratio or hazard ratio of 1.28 of all-cause in-hospital mortality in comparison to the general adult population. Let me explain what that means. Having chronic lymphocytic leukemia when you walk in the hospital door increased the chances of you dying when hospitalized for any reason by 28%. Those with CLL, not surprisingly, ended up staying longer in hospital and were more expensive to care for. CLL patients had higher odds of developing atrial fibrillation compared to those without CLL. They had higher odds of a serious cardiac situation where you develop fluid around the heart. That included cardiac tamponade, where the heart is being compressed by the fluid in the sac around it, and by pericardial effusions. The pericardium is the lining around the heart, and if there's fluid, which is called an effusion in it, it makes the heart work less effectively. The good news is that the odds of congestive heart failure were not increased in CLL patients. There was some interesting information that they found when examining this database in terms of what led to the higher inpatient mortality in CLL. That included some of the usual suspects, such as older age, male gender, black race, acute kidney injury, alcohol use, malnutrition, and this one, which I think people will not be surprised by, but was interesting, being admitted on the weekend. What really surprised me, though, was predictors for lower mortality while in hospital were smoking, and obesity. So what can we say in conclusion? What this research tells us is that CLL increases the risk of dying when in hospital and of certain cardiac conditions such as atrial fibrillation and fluid around the heart. The lack of information on the patient's medications makes these findings less valuable, but they're certainly worth knowing about. The strange outcome that smoking and obesity lowered the risk of dying in hospital may be a result of a lower threshold to admission for these patients, meaning they were admitted to the hospital a little less sick because of these risk factors, but its oddity demands some explanation from the authors. The problem with these retrospective data dives is they often leave us with more questions than answers because of what is and is not accessible in those electronic records. Still, we were reminded that CLL patients need to work with their doctors and practice a healthy lifestyle to lower not only their risk of heart disease, but of secondary cancers and other chronic illnesses. As we are living longer and longer with our CLL, these comorbid or other illnesses can become actually higher risk for us than the CLL itself. On the website, we provided a link to the abstract, Incidence, Predictors, and Outcomes of Cardiovascular Events in Patients with Chronic Lymphocytic Leukemia. Thanks so much for listening. Stay strong. We are all in this together.